second is maxillary composite superimposition, where you register on the lingual curvature of the palate, and the best fit on the maxillary bony structure is to assess the maxillary tooth movement. This is how the slope of the palate is evaluated. So here you can check how the molar and the incisors have moved. And this mandibular composite is registration on, there are again two ways: on internal cortical outline of the symphysis with the best fit on the mandibular canal to assess the mandibular tooth movement and incremental growth of the mandible. So this is where it is traced on the mandibular canal, superimposed on mandibular canal, and it is internal symphysis cortices are superimposed, and here you can see the tooth movement. If the canals are not seen, then other alternative is to trace the mandibular plane, superimpose the mandibular plane, and do a overlap on the cortical plate, or you can do it on the menton and the pogonier. So you can show both the maxillary and mandibular like this, sometimes along with the orbital, so that you can understand what's the change which has happened. So this is how the composite tracings at three places will look like. Also, there are sometimes you do Ricketts 5-point tracing on E-line, on the facial axis, on the nasion-basion plane, or the xi-PTM plane, and the internal. So this is a 5-point tracing by Ricketts. So you can do something like this as well. Now about the facial photographs, you must have good quality standardized facial photographs: frontal at rest, frontal smiling, profile at rest, patient facing to the right or left, additional views can be taken. It has to be either 1:8 or 1:10 ratio. Same magnification should be there in the pre, interim, and post records. End treatment records are in different, it is not accepted. Do not change the aspect ratio while cropping. The height width ratio, please don't change. Okay, and the supplemental radiograph also should be taken. I'll be Dr. Ashish, I'll be finishing in next 2 to 3 minutes.
Dr. Jayesh, please go ahead.
Yeah, okay. Because I was muted, so I don't know. I thought I had to stop. I'm going to just finish in 3 minutes. This is 1:6 magnification. This is 1:8. This is 1:10, and this is 1:12. So if you have a different magnification here in the pre-treatment and a different magnification here in the post-treatment, it will not be accepted. You have to have and photographs. I'm just going to give you please use that when you're doing intraoral photograph. Should look when you are taking the photo, the occlusal plane should be parallel to the lower border of the frame, and it should divide the photo into upper and lower equal half, and the midline of the dentition in the middle of the frame dividing into right and left equal half. So this is very important. This is how the photos are taken. And when you're doing the buccal, the occlusal plane should be parallel to the lower border. This is how it should be taken, the photos, and this is how it will look like. And these are the two intraoral photographs. The position of the photograph when you're taking the photo should be like this. This is how the photo should be taken, and this is how it should be clicked. So this will be useful for the part 1, part 2, and part 3 student. Very important is that correct the mirror view. The mirror effect should be eliminated. That's more important. This is how it will be, the occlusal photo for the lower. And please correct the mirror. Mobile photography is not accepted. And there are latest diagnostic records like cone beam, magnetic resonance imaging, digital models, where models and impressions and other things are evaluated. You can use them. You can use intraoral scanners. You can use cephalometric softwares. And if 3D photography is used, that is also accepted. CAD/CAM images is also accepted. If you have done a mounting, then the photographs of the mounting should be there like this. And you can use the IBO categories if you are having a little doubt. Category 1, 2, 3, IBO has defined, so you can use that. And this is the grading evaluation which you can use. But as I said, that 15 marks for each case is for the MDS examination. So in conclusion, we can say presentation of well-treated cases in exam boost your confidence, impresses the examiner. It helps grooming you as an orthodontic clinician. And as I always say, that anyone can be MDS orthodontists. Only a few are good orthodontists. The person who shows excellent treated cases is an orthodontist according to my definition. It motivates you from taking up further accreditations and certification exams. If your department permits and your HOD permits, you can take the nicely treated cases during your residency and appear for the MORTH and other examination. You may not take them for the board examination, it's not accepted, but you can use it for MORTH examination. It prepares you for the big world. And MDS examination, remember, is not the end. It is, in fact, I feel it's the beginning of you as an orthodontist. So it doesn't end at examination, it starts at the examination. So I would like to end my presentation with 3 important sayings which teacher Dr. Mistry sir has put up in our department. Replace the ambition to be first by the will to do the best possible. Replace the desire for success by the yearning for progress. Replace the eagerness for fame by the aspiration for perfection. And he used to always say that if the mind is clear and the heart is pure, there is no need for fear. So wishing all MDS Part 1, Part 2 and Part 3 students, thank you very much and all the best. I again thank my the president and the team and the Indore people, especially Dr. Ashish and team Aurobindo, for giving me an opportunity. Thank you very much. These are my contact numbers and these are my contact emails. You can ask me any doubt anytime. You can WhatsApp me your questions. I'll be also available for the panel discussion. So thank you very much and wishing a speedy recovery to the whole world from the pandemic of COVID-19. Thank you very much. Jai Hind, Jai Ayush.
Thank you, Dr. Jayesh, for the wonderful lecture. I think you have summarized the content beautifully in 30 minutes, like a 2020 cricket match. I think only you can do it in the most illustrious and a most informative way. Thank you so much. Really appreciate it.
Thank you.
Now, I request, yes, I now request Dr. Ashish to introduce the next speaker.
Shall I stop sharing my screen, Dr. Ashish?
Yes, please. I think there is some problem with Dr. Ashish's audio.
Yes,
I think I will take over and I will introduce the next speaker, Dr. Kiran Kumar, who's the professor and head at Bapuji Dental College. And he has a innumerable amount of experience in clinical practice and he's part of a premier institution in Bapuji, that is Bapuji Dental College, which is well known in the country for their contribution in the field of orthodontics. And I think the actual content of the introduction, maybe probably when Ashish comes, we will do that. As we are running out of time and we are running on a very tight schedule, I would request the speaker, Dr. Kiran Kumar, to continue. And he would be showcasing the 5 finished cases that is expected from a student in the PG examination. Over to you, Dr. Kiran Kumar.
Very good afternoon, sir. Very good afternoon to the organizing committee, President, sir, Secretary, Madam, executive members of the Indian Orthodontic Society, other dignitaries who are on the forum of today's session, senior colleagues, my teachers, my friends, my dear students. I welcome all of you for my presentation. I hope that sir, able to see my slide.
Please go ahead.
Okay, sir. Welcome back to the session. Very good afternoon. Just as most of you know, the college and some of the fresh candidates who have joined the MBS, this is a place from where I am working and when I completed my BTS and MTS.
Dr. Kiran, there is a lot of echo. Can you try to adjust the position of your mic a little bit?
Yes, sir. Actually, it's fine because of this network problem. Because previously also I had a lot of echo, sir.
Okay, fine.
Now I think
Right.
it's fine. It's fine, sir. Now
Yeah, it's fine. Please go
it's
ahead.
fine, sir. Okay, sir. It's my faculty, Dr. K. Sadashiti, sir, myself, Dr. Vijay, Dr. Prakash, Dr. Deepthi, Dr. Sharath, Dr. Karthik, and Sam. Actually, an exemplary literature has been covered by Dr. Jayesh Rahalkar regarding finished cases. So I'm going to present on these cases. So the specific learning objectives to drive the treatment of malocclusion, define the objectives of treatment, describe the mechanics, explaining the role of therapeutic diagnosis, exercising the mode of torture, defining the goals of finishing and detailing, and auditing the finished case. We have a patient by name Inna, who is a 13-year-old male patient. Chief complaint was on a forwardly placed upper front teeth. There is nothing significant familial history. The reasons for treatment is aesthetics, he is self-motivated, and is having a positive attitude towards treatment.
Dr. Kiran, can you try to be a little louder, sir? Little louder?
Yes, yes, sir. Yes, sir. Yes, sir. Yes. Hello, sir. Can you hear me now, sir?
Much better. Much better. Thank you.
Okay,
Hello.
yes. Coming to clinical examination, is mesodolgy facial with a convex profile and a posterior divergence, potential incompetent lips with a considerable amount of lip strain, everted lips, and deep interlabial sulcus. He has a full crown during speech and a full crown of plus 5 gums are visible during smile, indicating that he has a gummy smile. An overjet of 7 mm, overbite of 4 mm, molar relationship was done bilaterally, relationship done bilaterally. The most important aspect in this case is the arches are quite well aligned. There are not much of rotations or imbrications in the lower arch, which is going to help us in the later stages of the tree fixed appliance. Coming to cephalometric evaluation, cephalometric evaluation is mandatory in this case. Yes, because it's used to ascertain the configuration of the facial skeleton, relationship of the jaw bases, relationship of the axial inclination of the incisors, assessment of the soft tissue morphology, growth pattern and direction, localization of the malocclusion, treatment possibilities and limitations. Analysis indicates the maxilla with the retromandible deficient chin having vertical growth pattern, proclined upper and lower incisors, caudally tipped occlusal plane, lips of retrosive. MAC number analysis also reveals orthoptic maxilla, retrotic mandible, vertical growth pattern, increased lower interfacial height, forwardly placed lower incisors. Precoci Jarabec analysis reveals this was vertical growth pattern, palatally crane tipped, divergent jaw bases, proclined upper and lower incisors. Sparse analysis gives a relationship between the ramal length, maxillary base, mandible length. It's very well known that in the in-laws counterpart principle that this particular structures, the ramal length, the maxillary base, the mandible base, and the anticranial base are all counterparts to each other. Coming to diagnosis, it's a class 2 skeletal case with an ENB of 8 degree, displacer showing a wide of view of 7 mm, having a non to class 2 molar and canal relationship bilaterally towards vertical growth pattern with forwardly placed and proclined upper and lower incisors. So what causes a dentofacial deformity? Dentofacial deformity is a developmental problem. Occasionally, the deformity is due to a single specific cause, or more frequently, it arises from a complex interaction among multiple factors that influence growth and development. So, coming to nasomaxillary complex development, because in this case, we came to know that maxilla is a problem. So, postnatally, maxilla develops entirely by intramembranous ossification, that is, surface remodeling and opposition of bone to sutures. So how is this growth accomplished? It is accomplished in by 2 ways, cranial base growth and growth at sutures. Cranial base growth is an important part of the maxillary growth which displaces the entire nasomaxillary complex anteriorly and inferiorly. Later stages of growth, when the cranial base growth stops, the growth of the soft tissue translates the maxilla downwards and forwards, opening upwards the suture systems, which is filled in by proliferation of bone and simultaneous surface remodeling. This is very important point to be noted is that the stimuli from the enveloping soft tissue plays an important role from age 7 to 15, where it coincides with your pubertal growth spurt. The vertical growth of the mandibular condyles and the descent of the glenoid fossa. Vertical growth of the mandibular condyles and descent of the glenoid fossa balance the vertical movement of the lower limb process and the body of the mandible. This is very well explained by allied forces or opposing forces as by J.F. Scudi. In his classical articles, he explains in detail the role of these allied forces or opposing forces are also known as growth forces. So the harmonious positioning of the maxilla and the mandible related to the cranium not only facilitates the ultimate function of the jaw and teeth to break up food mastication, as spoken by Prophet in the year 1983, or by also forms the analytical basis of pleasing facial aesthetics as given by Bishara Jacobson. So what are the treatment objectives in this case? To match the skeletal bases, to reduce midfacial convexity, to achieve lip competency, to achieve class 1 molar and canal relationship, to achieve wide lower jaw and overbite, to achieve a balanced and pleasing profile. Coming to the discussion part in this case, before we start treating a case, we need to have an in-depth discussion about how to treat this case. So we have covered about what happened in growth and development in this case in relation to the maxilla. So what are its counterparts? What are the problems? So problem is in both vertical and sagittal plane with very negligible amount recognized in the transverse plane. Vertical descent of the maxilla has resulted in downward and backward rotation of the mandible. Because of this, the vertical growth, the face has become more longer. But the normal growth of mandible, could not position the chin in relationship of the face. That is why, in this case, it is becoming class 2. So how to handle this? Now, the most important thing we have to know is the vertical growth of the mandibular condyles and descent of the glenoid fossa should have balanced the vertical downward movement of the maxilla, upper alveolar process and lower alveolar process, which didn't happen in this case. So the treatment plan is to go for an activator combination. Activator will propel the mandible forwards, thus utilizing the concepts of functional appliance. Activator combination will have operating effect on the lower incisors, thereby loading the maxilla, thereby controlling the vertical and forward movement of the maxilla, thereby preventing the normal translation of the maxilla, which could occur by growth, allowing the mandible to express its full potential, and later stages, a non-extraction treatment could be accomplished. The patient is placed with an activator with force passing through center of resistance. And it is very well known that we do have center of resistance of dentition and a center of resistance of maxilla. After placing an activator appliance with the headgear combination, we have to make sure that the force passes through the center of resistance of the dentition and the maxilla. So how to judge whether the force is passing through the center of resistance of the dentition of the maxilla? There are two methods. One is a clinical method and a cephalometric method. So it's very well known that we can't be exposing the patient for radiographs. Clinically, when after placing an activator and if the force is passing through the center of resistance of the dentition of the maxilla, the appliance will not rock. The appliance will not rock. If the appliance is rocking, that means the force is not passing through the center of resistance of the dentition of the maxilla. Following that, for an academic purpose, what we can do is we can take a lateral cephalogram with the appliance so that we can resolve the components and we can come to know that whether the force is directed at the center of resistance of the dentition and the maxilla. These are the post-orthopedic photographs. We can see a remarkable change. We can see a very remarkable change in the vertical position of the incisors. In some cases, it will be so effective that we can see disappearance of the maxilla and the maxillary dentition. The effect will be to such extent that we have to keep in mind that the later growth will come into play a major role, thereby allowing the maxilla to descend downwards. Following this, patient was strapped with an O2 slot, MBT brackets, and MBT mechanics is followed. Patient was placed on upper and lower O6 and O4 NITA wire as aligning and leveling wires. Following this, we have shifted to an upper and lower 1925 native. There's an immediate shift from 1.6 or 1.4 to 1925 native in this case, because as I covered in my previous slides, there is not much of rotations, imbrications, or first order or second order problems. So when we have a case where there is not much of first order, second order problems, that means we can step up our wires quite easy, and we should come to a rigid wire at the earliest so that we can stabilize the arches. These are the post-treatment pictures. Pre-treatment, post-treatment, and a follow-up showing a remarkable change in the position of the mandible, the chin, the impairment which is there in relation to the lips, which has greatly been addressed. These are the frontal pictures. And we have to make a note here. The puckering which was there on the lower part of the chin has not completely disappeared. At this point of time also, we can make out sure that there is some amount of incompetence which is there. So should we be worried about this? No, because the soft tissue growth is still left. And there is one more important thing we have to know is the contribution of accretional growth. It was Behrens who did a lot of studies in relation to the later amount of the changes that can be seen in adult. And there is a very well documented there that the accretional growth plays a very important role in unmasking this type of lip incompetency, and we should not be much worried about it. These are the intraoral pictures where we were able to achieve. We were able to reduce the overjet, improve the bite, achieve class 1 molar relationship, class 1 relationship with midline coincidings. And the overall cephalometric superimposition also depicts the changes what we wanted in this case. So we were able to reduce the ENB angle, harmonize the jaw issues, and also have a good control on the upper and lower incisors. So an activator Edgar combination was able to bring a remarkable change in this patient underlying skeletal problems. Come to my second case. Patient girl, she has 12 years, she complaint of irregularly placed teeth. She is mesocephalic, mesofacial, convex profile with posterior divergence and potentially incompetent lips. She had an overjet of 4 meters and overbite of 4 meters with moderate crowding in the upper arch and in the lower arch, which is 2 in prospect. Molar space end down bilaterally, and insertion space class 2 division 1. These are pre-treatment radiographs. I request all of you to have a clear view and remember the position of the canine, which I'm going to cover in my later slides. Extentation analysis revealed a tooth metal excess of 5.1 mm in the upper arch and 4.5 in the lower arch. She was diagnosed as a 12-year-old female patient with end-on motion bilaterally, superimposed on class 2 skeletal basis with vertical growth pattern with upper and lower anti-crowding and potentially incompetent lips. So what's the treatment plan? Observe so as to allow the dentist to shed on their own. Phase 2, drift orthodontics with extraction of first premolars in all quadrants, followed by fixed mechanical therapy to detail the occlusion. She was kept under observation. We know that she is not yet attended puberty. Lot of amount of growth is left, and the teeth have to shed. So we allowed a natural phenomenon that can be where natural shedding of the teeth can take place instead of we intervening at this point of time. And during this 1 year observation, what happened? The canine position worsened a lot. So should we be worried about it? No, we should align extraction of teeth, and if space is given, the canine uprights. So following our 1 year 6 months observation, at this point of time, following the loss of the disc teeth, the canine is uprighted. So sometimes we have to rely on the natural forces that are all responsible to maintain the arch integrity and how it can play a very significant role in uprighting the dentition. The orthodontic profession has long recognized the need for extracting teeth when supporting bone is insufficient for the amount of tooth structure present, or the underlying condition makes us that we need to extract the teeth and retract. So the next big question is when to extract and when to initiate mechanotherapy in a growing child. Traditionally, the extraction of teeth has been immediately followed by appliance therapy. And this practice is still the most common approach which is practiced by everybody to prevent adverse and unwanted tooth movement, especially of those teeth adjacent to the extraction sites. Sometimes doing nothing is doing something. Potential benefits from a period of physiological dental drift post-action was first proposed by Bordet. He spoke about better and stable occlusal relationships, increased dental support, a shorter period of full appliance therapy owing to spontaneous realignment of the dentition. Hence, she was placed on holding arches in the upper and lower arch with extraction of force. Physiological drift, commonly referred to as driftodontics, following premolar extraction was first found by Alexander. The advantage of extracting and letting teeth drift is a self-correction, self-separation that can occur so rapidly under the influence of molding pressure of the tongue on the soft tissue drape supported by the dynamic occlusion. Physiological drift after extractions can significantly simplify treatment mechanics and reduce treatment duration. And the most important thing in this case is it will be the forces which are used to align the teeth. That means it will be very optimal. It will be very optimal. And following driftodontics, 50 to 60% of already your alignment is already done by your natural forces. The rest, what you have to do is to upright them, bring into proper position, and settle the occlusion. So we started with aligning using 175 coaxial wire with lace plates following driftodontics, following which she was placed on upper and lower 148 wire. The treatment progressed and she was placed on upper and lower in 6 Australian special plates with open coil spring to create space in relation to the third quarter. She was placed on upper 148 and lower 1620 stainless steel with more auxiliary. And everybody, I hope that everyone of you know that more auxiliary is one of a very important auxiliary which can be used to move a tooth bodily. We know that a bodily position lateral incisor, as such in this case, where lateral incisor is bodily position. So when you engage a wire, when you deflect a wire, what happens? There is a pure force acting on this tip. So the crown moves, the root position is the same. Until unless we bring the root proper into the bone or into the part of the arch, it's going to relapse. So it's a very important point to be noted that the torque, the labial angle inclination of the incisors is a must for the stability as suggested by Boston. She was placed in finally, once the teeth are aligned, she was placed on upper and lower 19 stainless steel and 17 stainless steel with class 2 elastics to correct the molar interarch relationship. Later, she was placed on upper and lower 16 to 20 braided stainless steel wire with settling elastics. Now the question comes regarding the use of settling wires, which one to use. In some books tell one wire, braided wire, dimensions are available. The utilization of the settling wire depends on initial malocclusion and the severity of the malocclusion. In the finishing stages, it's always better to use a 1622 or 1725 1925 braided wire so that you can maintain the bite and also the torque. In some cases where the bite is quite shallow, where you need to settle the occlusion, it's always better to come for a low load deflection wire, something like 1.2 or 1.4 wire, and use vertical elastics which help in settling the occlusion. And where there are certain cases where the task discrepancy was addressed, in those cases, it's always better to use a stainless steel wire like an 1.4 or 1.6 stainless steel wire because the transverse corrections can be maintained. These are the post-treatment pictures where we are able to achieve quite good occlusion and a facial balance and a lot amount of complementary growth supported in this case since the treatment was carried out during the period of the growth. But one part you have to know is there is incomplete retrieval of the gingiva which needs. This is because the teeth, especially the canines, the lateral incisors were not in occlusion. The canines and the lateral incisors came into occlusion following the alignment of teeth. That means a sufficient amount of time needs to be given for the occlusion to settle because the occlusal forces play a very significant role in the bone architecture, which significantly influences the soft tissue covering, that is the gingiva. These are post-treatment lateral photographs and OPGs. These are follow-up photographs. Coming to the discussion part, this patient has decided to keep the patient under observation, taking into consideration favorable growth available. Since all the remaining listed teeth are mobile, it was decided to wait for sitting on their own instead of active intervention by extracting and placing the patient on holding arches. Following observation, extraction of all fistulas were done, and the patient was placed on upper and lower holding arches with posted composite to gag open the bite. That means to open the bite and relieve the occlusion, and allow for spontaneous cross the following drifting. The result for allowing physiological drifting of teeth was to take the advantages of the growth of the patient and the soft tissue changes that will be favorable in this patient. Following natural declouding of the dentition, aligning and leveling was accomplished, and final detailing of the occlusion was done using fixed implants. Later, patient was placed on upper big retainer and lower bond retainer. These are the sequential photographs of the same patient where initial observation, then following extraction, and this is the follow-up. You have to observe how there's a significant improvement in the lip architecture, the competence of the lips, the chin position, and especially from post-treatment to follow-up. From post-treatment to follow-up, there's a very big remarkable change, especially in relation to the lower chin, which adds a lot of aesthetics to the balance of the face. Here we have a patient by Sagar, who is a 12-year-old male patient with the chief complaint of irregular plus upper front teeth. It's a class 1 malocclusion with significant amount of crowding. These are our pre-treatment measurements, which clearly indicates it's in a typical class 1 skeletal having horizontal growth pattern where your palatal plane, your mandible plane are more or less parallel to each other, 80 to 100% of growth is remaining. The concept of segmental arch mechanics. In orthodontics, we have sectional mechanics, segmented mechanics, arch mechanics, bypass mechanics, continuous arch mechanics. Which one to use, when to use is all dependent upon the underlying malocclusion. In this case, the canines are highly positioned. So, wanting the incisors, you will need to bypass. And the wire which is free here can play a significant role in having its deleterious effect on the canine. And we know that the canine which is placed buccally is having a very thin cortical bone in this area. So any force which you try to apply a force on the canine will move the canine palatally. In the case, what happens, the root which is going to move buccally, that means you are going to lose the bone. So it's very important that we should not touch in these cases. In these type of cases, what we can go for a sectional mechanics. We do sectional alignment and leveling. Following sectional alignment and leveling, we can go for distalization. Distalization of the arches can be done using head gears, using inter-arch mechanics, because we wanted to utilize the growth in this case, offset the growth direction. So in this case, the force vector is inferior to both center of resistance of both the maxilla and the maxillary dentition. Since this force is acting in a distal direction, below the center of resistance of the dentition and the maxilla, you have a clockwise movement is getting generated. Because of this clockwise movement, what happens? The dentition tries to extrude. The dentition tries to extrude. It's going to offset the mandible, which tries to move the mandible downwards and backwards, thereby helping in opening the bite. This is also known as a functional appliance-like effect, because when the dentition extrudes, it creates point of eye contacts. This will create a disturbance. This will create disturbance in the occlusion, which will lead to eruption of the posterior teeth, because the teeth can't be brought into occlusion because of the tenderness, and this will allow for the vertical eruption of the teeth, which leads in natural bite opening, contributed by the growth of the condylar growth of the mandible. So, following the distalization, what happens? When the arches gets distalized, space is getting created. Now, the shoulder joint will come very near. It comes in close proximity of the incisors. So, we need to offset it. So, there are very innovative methods are there, like where we can use rings, we can use metal sleeves. So, in this, we use a customized 0.7 mm wire where we made coils, and this was soldered so that it will offset it, thereby preventing its close proximity, or which can traumatize the incisors. This is a pre-treatment and post-treatment pictures. Yes, a very good amount of distalization was achieved. We were able to achieve class 1 relationship, class 1 relationship with midlines coinciding, and a very well very well stabilized occlusion at the end of the treatment. These are post-treatment pictures. There's not much change. There's not much change in his face except the positioning of the chin. Except the positioning of the chin. If this patient was not would have been treated, he would have become a severe horizontal growth pattern where if after cessation of growth, if this patient would have reported, possibly you could not have done extraction, not distalization. Hence, you could have subjected the patient for a full-fledged surgical line of treatment. Hence, attempting it to patient at right point of time can bring about a remarkable change and avoiding major treatments in the later stages of the case. So these are the changes that has been observed following pre-treatment. So another 10 minutes more, sir. 10 minutes more.
Please summarize it.
Now next we have the next patient by name PB Pusha. She is a 19-year-old female patient. Looks more of in a class on Bimax protrusion case. Yes, it's a class on skeletal base with an ENB of 3 degree. Orthodontal maxilla and mandible and horizontal growth towards vertical growth pattern with forward placed proclined upper and lower incisors. Definitely, this case could have been treated by numerous methods. You can treat this case definitely requires extraction. You can treat this case by begging mechanotherapy. You can treat this case by edgewise appliance. You can treat this case by lingual mechanotherapy. You can treat this case by with aligners. There are empty number of ways to treat a case, but appliance of choice is determined by finally what the results we need to have in this case. Extraction of 4 first nerves followed by fixed mechanotherapy using first student 2-dimensional lingual self-ligating appliance. It is used for the correction of simple malabsorptions such as minor clouding or spacing. It is easy to use because these brackets have no slot. They include small wings welded to the bracket base, and these wings are used to secure the archway. Outstanding patient comfort, extremely low profile, and are barely noticeable. So following initial aligning, using 1 to 9 upper and lower arches, we know that in this case, there is a significant amount of proclination and the soft tissue drape is very good. So the lip pressure itself is sufficient enough to align this teeth and reduce the overjet. The later stages, we went for 116 in upper and lower arches. You can recognize here there is a lot of decrease in the extraction space, which is taken well under the influence of the soft tissue drape. In the later stages, we have shifted to upper and lower central stainless steel with class 1 mechanics, connected with the traction, and we have to come to the torque check because torque is very, very important. As such, as given by Burstall, that positioning of the upper incisors plays a very significant role in the stability of the overjet, overbite, and the guidance of the dentition during all the excursions. So in this case, the torque requirement was about 10 degrees. So to obtain the torque, so this is the way we went for a modified Molina's aligning auxiliary, where it was a mousetrap auxiliary was used in this case with a base arch where 1.8 and 1.4 the rod trap auxiliary. So this is how the auxiliary looks when it's placed. Why we need to use an auxiliary in this case? Because we, as I said, this is 2D brackets. You don't have any slots, and you know that the inefficiency of the pre-stitched edgewise appliance is the slot. The slot is inefficient in third order control. So we need to have some extra slot mechanics, which plays a very important role in generating good amount of moment to force ratio. So the biomechanics part of this is we have the base arch, and this is its passive position. Then you engage it and move it in occlusal direction. So at the end stage, what happens? You have the auxiliary position in this particular fashion, which I'm going to explain in the next slide to get the biomechanics part. In its passive position, the arms are facing, arms are parallel to the palatal plane. Now, when you want to engage, you have to move, engage. What happens? Once you engage, what happens? The auxiliary tries to come back to its original position. That means it's pressing, it's having a 2-point contact. So that means in a 2-point contact, that means you get a couple generated. And you have a moment which is getting generated because of this couple, and that is called a moment of couple. Irrespective of the point of application of the couple, the tooth will rotate at center of resistance, but the tooth can't move because it is secured by the archway. Now you have to negate this crown movement and increase the efficiency of root movement. So how to do it? So negate this crown movement by use of intermaxillary elastics. When you use intermaxillary elastics, you have a force which is acting. So this force is also going to generate a moment of the force. Now this is going to negate the crown movement, thereby increasing the moment of force ratio of 10:1 or 13:1, where the center of rotation will be at somewhere at the bracket level, and that's how you get a root movement and helps in better positioning of the incisors. These are post-treatment pictures. This is how we were able to finish the case. This is the cephalometric superimposition depicting only dental changes here. We didn't do anything much great in this case. With significant change in the labeling of the incisors brought a remarkable change in the soft tissue architecture and the soft tissue balance. Contributing to what we can do is we have to need to evaluate cases. So we have ABO grading, where you can do ABO score. You can use IoT index, which can be part of your regular evaluation of the case. And we have the dental component. Then we have the peer assessment rating index. Once you finish all your case, it's better that you audit your case and do a scoring for all your cases. And if it's successfully done, one by after the other case, what happens, it will give a good insight into your methodology of treatment, that where we are going wrong and how to improve and to finish and detail the cases. And this is how during the practical, I know that Jayesh said extempore covered regarding the marks allocation one more time. And so I'm telling that it's functional case, appliance delivery, multi-banded exercise, preclinical work, 5 cases treated case display. In 5 treated case display, you can show importance to diagnosis and treatment planning, mechanics, interdepartmental referral cases, and any extempore use of CAD CAMs and use of TATs, and where a surgical case can also be added. So there you are going to showcase your cases in various categories, and you can show that how one case can be treated by so many methods, or what are the other available modalities. This I come to my end of my session. The rich academic and clinical life associated with my department is made possible by students. To all of you, my grateful thanks. This is the upcoming book from our department, a case-based atlas of comprehensive orthodontics. And I sincerely thank the organizing committee, the president sir, the secretary madam, event a great success.
We orthodontists are slightly weak in chemistry. You know, we are not very keen to know the basics of the chemical part, and neither are we, taught that in detail much. So what happens is that while we are bonding our case, it's not only the position of the bracket which is important, it's also many other factors which come into play. And many times we are caught in a sorry figure while we are dealing with the examiner and answering our questions. So my presentation will basically focus on how you can overcome these lacunae and answer well in your PG exam. We all know that orthodontists cannot work without brackets. And, it is a difference that earlier orthodontists who were senior used to do banding, but now banding is gone. Why it's gone? Because of the issues of aesthetics, the issues related to patient discomfort, issues related to arch length increase. You are placing separators on all teeth, so you're increasing the arch length. Inaccurate, welding of your attachments. Maintenance of oral hygiene is an issue. Also, there are other issues. You have partially erupted teeth that cannot be banded so easily. The interproximal areas are not easily accessible. And many times when we want to do IPR, if we have banded, we will not be able to do so well. Also, band spaces are difficult to close at the end of treatment. Therefore, now bonding is the order of the day. So how did this bonding come about? It was Dr. Buccal in 1955 who gave us landmark article on a simple method of increasing the addition of acrylic filling materials to enamel surfaces. He used 85% phosphoric acid for 30 seconds. Now, try to understand that this didn't come from a space. They were working on the paint industry. And in the paint industry, what happened is that they learned that if you wanted to attach anything onto a metal surface, you have to prepare it with an acid. And while preparing it with an acid, you could easily etch things on top of it. Therefore, this concept was brought into orthodontics, and this saved our day. Now, issues come up when we want to know that should molars be banded or bonded. it is said that there is an inferior quality of the edge pattern on the molars. Also, there is difficulty in obtaining moisture control. There is difficult to adapt the bracket base to the molar. Also, the vertical bulk of the molar tube design on the tie wing is an issue. And also larger masticatory forces on the molar. So would you like to band or bond a molar? The question is that if you are using lingual auxiliaries, when you are using headgears, it's always the good thing to band rather than bond. So this question will be answered by you easily when it's asked in the exam that why bonding versus banding and which conditions on the molar would you like to band versus bond. Now let's look at what needs to be kept in mind for successful bonding. You need to clean the tooth surface and prepare it, design of the attachment base, the bonding material, and the bracket placement guide. These are critical factors. So the first step is cleaning. We often omit this. We directly come on to applying the etchant and start bonding. So the most critical aspect, first step in bonding is cleaning, followed by enamel conditioning, sealing, and then bonding. So let's look at why and how to clean the teeth. Well, why is it essential? It's essential to remove plaque and organic pellicle that normally covers all the teeth. Even for self-etching primers, it's advisable to do cleaning. And this is the method for gross removal of plaque. The buccal surfaces of the second molars are the more particular areas for plaque retention. Now, how do you do this cleaning? You use pumice powder and you use either a rubber cup at low speed or a bristle brush. What is preferable? A rubber cup is preferable. Why? Because you don't want to injure the gingiva and cause bleeding at the time of bonding. What about cleaning the enamel? Enamel preparation is done to create surface irregularities and increase the surface area. We all know that bonding is basically not a chemical reaction which is happening. It's a mechanical retention between the surface irregularities created on the enamel surface as well as the resin which has percolated in and cured. So, what are the different ways to prepare enamel? This is what an examiner would ask you. So, there are 4 known ways. One is acid etching, one is crystal growth, one is air abrasion, sandblasting, micro etching, or laser etching. So you have different ways of preparation of the enamel surface. We'll go into acid etching last. Let's start off with each method. What is crystal growth? A very simple phenomenon. Polyacrylic acid containing sulfate ions react with the calcium in the enamel to form small and dense needle-shaped crystals. So the bond strength obtained is 50 to 80% of that which is achieved with acid etching. Therefore, crystal growth is not very popular. So what is crystal growth? Polyacrylic acid reacting with the enamel and forming dense needle-shaped crystals. Then what is micro etching or sandblasting? We are using 50 microns or 90 microns of aluminum oxide particles propelled at high speed onto the enamel. What does it do? It substitutes for cleaning before etching, but it's not a substitute for etching. If you were to clean or sandblast, that would be almost similar. But if you thought that you were actually substituting acid etching, it's not correct. Laser etching, ND-YAG lasers used to bring about localized ablation. Localized ablation by increasing the temperature and micro explosions of the trapped water inside the enamel. So what is the issue? The issue is you don't want to increase the pulpal temperature and damage the tooth. You don't want to produce lower bond strength because the bond strength with laser etching are lesser than enamel etching. Now, acid etching, which we usually do, there are 2 issues. We want to control the moisture and also we want to prepare the enamel. So how do you control the moisture? There are lip expanders, salivary ejectors, there are tongue guards, bite blocks, salivary duct blocks, cotton or gauze rolls, and all these are the armamentarium. And also an issue is anti-silogogues. So banthine tablets or atropine sulfate are recommended. But what does literature say? Literature says that anti-silogogues have no difference. In fact, a systematic review published in the year 2010 by Anne-Marie Cooper-Jackman and group says that an anti-silogogue used or not used, your bond failure rate remains the same. Now, why do you do etching? What does etching do? It removes the fluoride-rich surface layer and it removes the small amount of softer interprismatic enamel, opens up the pores between the enamel prisms. So what are you doing? You are creating microporosities within the enamel and also reducing the surface tension that allows the resin to penetrate and polymerize within the etched enamel rods. So that is what is the objective of etching. Also, there is an issue that whether you want to use a gel or a solution, and also you want to actually this standard etchant will dissolve about 5 to 10 micrometer of enamel surface and create a zone of rods for about 15 to 25 is the depth of penetration. So many examiners will ask you whether when you are using an etchant, will it actually destroy your enamel surface? No, it doesn't. It penetrates very little onto the enamel surface. That we had to choose why we do bonding versus banding, which was done earlier. Why would you like to choose to do banding in some cases on the molars even today? What are the different methods of cleaning your enamel surface? Why you need to prepare your enamel surface? So now in the midst of it, we need to know how to apply the acid and how long it should be applied. So, it should be applied with a foam pellet and brush for about 15 to 30 seconds. The realistic etching time for permanent teeth is about 30 seconds, and for deciduous teeth, it is more. We'll just come back to it, why it's more, and the bond strength which would be acquired if we use this particular setting. Now, why 37% phosphoric acid? Well, 10 to 37% phosphoric acid gives the highest bond strength. If we were to use more than 50%, what is the harm? The harm is formation of monocalcium phosphate monohydrate. So this, what it does is that it doesn't allow the further dissolution. So the penetration of the enamel rods will not happen to the depth we want it to be to give adequate bond strength. Malic acid has been suggested by some, but the bond strength is lower compared to phosphoric acid. Now, why more time to etch deciduous teeth? Now, what is the aim of etching? It's opening the interprismatic areas during etching. Well, deciduous teeth often show prismless enamel on their outer surface. So it's a good idea to micro etch with aluminum oxide before acid etching to remove the prismless enamel layer. So the time required for etching deciduous teeth is usually more compared to the permanent teeth. Now, do I need to etch fluoridated enamel more than normal enamel? No. The etching time required for fluoridated versus normal enamel remains the same. Now, why do you clean? Once you have applied an etchant, you want to rinse and dry the surface. What is the reason for rinsing? It's often misconceived that rinsing is to remove acid from the tooth. It's incorrect. Acid removal is only a secondary need for rinsing. The primary reason is to remove calcium monophosphate and byproducts of sulfate, calcium sulfate, and phosphoric acid byproducts. So if these byproducts are the reason why we need to clean the surface, never attempt a wet cotton roll and attempt to wipe the acid off. You need to have, because what is this going to do? It's going to fracture the enamel rods and weaken the bond strength. So you need to apply the liquid etch for 10 to 15 seconds and a gel etch for 20 seconds. Why liquid etch? Because this is going to spread and might even damage your gingiva. So this is the appearance you are going to get, a dull, frosty, matte or whitish appearance. So this is what is the objective of good etching. Now, etching under a microscope. You will be asked by the examiner, what are the different etch patterns? Silverstone has given 5 etch patterns. One is central type. You can see a central etching. The other is a peripheral type, when you can see the heads and the tails of the enamel rods. The third one is the less structured etch type. The fourth and the fifth ones are the ones you don't want to get. One is pitted enamel surface, which looks like an unfinished puzzle or a jigsaw puzzle. And type 5 is a flat, smooth surface. So this is what you don't want to get if you want to etch the teeth properly. Once you prepare the enamel, next what? You want to do sealing. There is a liquid in the bottle. You apply it with a brush. You dry it and cure it. So this is a thin coating of the bonding agent, and you shouldn't use excess of it. Why? Because if you use an excess, there's going to be a bracket drift and unnatural enamel when polymerized. Thickness will be much more. These are the different types of generation of bonding agents used because we are dealing with enamel. You know, the difference between orthodontic and dental bonding is that the dentists are working on dentine while we are working mostly on enamel. So generation 1 is an NP-GMA, generation 2 is HEMA, generation 3 is 4-META, and generation 4 and 5 are basically used for, in wet conditions, the hydrophilic primers and the one bottle systems. Why self-etching primers? Self-etching primers become popular because they combine the etching and the priming steps. I told you that we still would like to do enamel cleaning before we do use a self-etching primer. So what is this? It's basically a meth-acrylated phosphoric ester. So it's a meth-acrylated phosphoric ester. What does it do? It dissolves the calcium and removes it from the hydroxyapatite. The primer molecules penetrate the enamel rods after the etching process. So priming and etching is happening together. So, you know, you don't have to apply a primer as the second step. So how do they look like? It's like a lollipop where there are some, photo initiators which will open up only once light is there, and the second compartment having water and soluble fluorides, having a brush. So it looks like a lollipop, and this is how a self-etching primer is available to you. Now, what is an adhesive? Adhesive is nothing. It's but a glass or ceramic particles which are dispersed in a photopolymerizable synthetic organic resin matrix. So it's an organic resin matrix which has got glass or ceramic particles in it. And it, this can be when we apply a particular light of a particular intensity, it is going to polymerize. It's basically a combination of silane coated inorganic filler particles. So what are they? They are either bis gamma or UDMA. So these are present, and sometimes you have chromatic substances added for color changes. They'll tell you whether the full curing has happened or not. So you have to understand that an adhesive is basically a blend of glass or ceramic particles dispersed in an organic matrix. This silane coated inorganic filler can be a bis gamma or UDMA, and there are some chromatic materials which could be added. Now, what is the minimum bond strength? The minimum bond strength adequate for clinical use according to Reynolds is 5.9 to 7.8 megapascals. You have to be careful that you don't want to go beyond this bond strength because you don't want to damage the enamel. So if you look back, fracture in enamel can occur with bond strengths as low as 13.5 MPa. So, the tensile bond strength of enamel is 14.5 MPa. So one has to be careful not having a stronger bond. Sometimes the stronger bond on teeth which have got micro cracks are going to damage your tooth itself. Now, how to bond in wet field? Many times it's a problem. You have an impacted canine and there is blood contamination. You are very close to the second molar or a premolar which is not fully erupted. There is cervical fluid or a second molar where you want to bond. So there are two formulations developed. One is called moisture resistant adhesive and the other is moisture active adhesive. Try to understand how they work differently. The moisture resistant adhesives, basically Azure and MIP, they are a primer formulation and are based on hydrophilic attraction of its constitution. Hydrophilic means water repelling. Now, they are basically meth-acrylated polyalkanoic acid copolymers. So, difficult to remember, but we have to remember that they are basically meth-acrylated polyalkanoic acid copolymers. And these are basically, popular in dentine bonding agents, because the amount of water content in dentine is much more than water in enamel. So, the excess interfacial water ionizes the carboxyl groups, forming dimers. And with this, dynamic equilibrium occurs at the interface. So moisture resistant adhesive actually have the component for repels water, and it's the sealant applied 10 seconds, lightly dried and then light cured for 10 seconds. What about the moisture active adhesives like Smart Bond? What's the difference? The difference is that these are cyanoacrylate based. Now cyanoacrylates react with water. They need water for formation of the corresponding amines. So the amine reacts with the residual isocyanate groups, and an adhesive is adhesive bond is formed substituting the urea groups. So what is the difference between them? The difference is very clear. One which repels water for bonding, one which needs water for the bonding process. So moisture active adhesives have cyanoacrylate groups. The moisture resistant adhesives basically have a hydrophilic attraction between its components, and they are polyalkanoic acid, polyalkanoic acid methacrylated functionalized groups. So that is the difference between the two. Now, what do you do when you need good bracket tweezers? They, many times we go for an exam, we find that the bracket tweezers are very unclean and not kept well. They need to be very clean and they need to be autoclaved before use for every patient. After placing the bracket, you have to press so that the excessive flash is removed. And this is a very important part of bonding. You need to look at the tooth surface from a mirror, indirect vision, to be able to place the brackets. But something which is very popular and examiners will ask, which you will not be doing in the exam, is indirect bonding. Indirect bonding was described by Silverman because it's more accurate, saves the orthodontist time, avoids bad fitting the posterior, makes it easier to bond the posteriors, and also it's better moisture control. However, these are more vulnerable to breakages, and you may require silogogues to be used. So just be aware that you need to be a bit vigilant about another method of bonding, which is indirect bonding. You are fabricating an indirect bonding tray and then you are curing. So this is another method of bonding. Well, different light sources are the question which the examiners are very keen to ask. What is the most common way used earlier? That was tungsten, quartz, tungsten, halogen. So what was it? It was electrical energy which was heating a filament, and there was blue light being produced. Now the problem was that there is, we were very good at bonding. Densply had this unit, and I started my career bonding using this unit. Now the problem is that when you put on the electricity, you've bonded the case, you immediately switch it off. That's a problem because there is a fan here, and this fan is, it is cooling your filament. So if you switch it off directly, it's going to damage your machine. So you should wait till the fan is switched off automatically. You are using it for 20 seconds or light cure modified GIs for 40 seconds. Argon lasers can be used. The light, it's 418 nanometer wavelength, and the light is collimated and is more consistent with having power density. Not all of us have lasers. Plasma arc. Plasma arc is a light which is filtered to the blue wavelength with a narrow spectrum of 430 to 490 nanometer. So this is using a quartz tube filled with xenon gas. Now, only 3-second cure is there. So if you were to bond multiple brackets, 3-second cure, this is the best way for curing your teeth. But as students, we usually are using LEDs. They are very cheap. We get them at a very reasonable price from the market, and they last for a lot of bonding. So 1995, it was Mills et al. Who proposed solid state LEDs for polymerization. Basically use junctions of doped semiconductors to generate light. They directly emit light in the blue region. Now, where to place the bracket? Whatever philosophy you're using, you want to place it at the FA point or the center of, this is called the FACC or the facial axis of the clinical crown. So you look at the facial axis in the midpoint of the FACC and want to locate the bracket at that particular point. Now, how did the bracket positioning chart evolve? Now, I recommend that whenever you are bonding, always have your study models with you and also have your OPG with you. So you have a very good bonding kit with you, which is sterilized and autoclaved and in place, as well as the diagnostic records of the patient. Now, how did this bracket placement chart develop? All of us use this, but we are not aware how this chart came into work. The series of articles by McLaughlin in the Journal of Clinical Orthodontics in 1995 brought about the evolution of the bracket placement chart. What was part one of the study? You know what they did? They wanted to look at what would be an ideal position of the bracket to give a good finish. So they used the anatomical crown height. What is the anatomical crown height? That part of the crown which is covered with enamel. So, you know, when the tooth erupts, many times we are not able to measure the anatomical crown height because the cervical area is covered by gingival tissue. So what we see is basically clinical crown height. So what they did was that they looked at the anatomical crown heights of teeth which were finished well. The cases with the Andrews 6 keys to occlusion, and they found that if they halved the value from the anatomical crown height to the incisal edge, they made a table. Now, in the second part, they looked at the clinical crown height, what was visible to us as a clinician and what was uncovered. There was no gingival tissue on top. So these were also calculated half and made a table of. So what did they observe? They observed that the distance from the incisal or the occlusal edge to the center of the clinical crown was only 0.5 millimeter less than the distance from the anatomical crown. So, you know, they gave something which is known as the theoretical bracket placement chart. They said that you round off to the next 0.5 mm to produce a theoretical bracket placement chart. So values of 0.5 and 1 mm were added for larger teeth, and values of 0.5 and 1 mm were subtracted for smaller teeth. Now, something very peculiar they found. You know, evaluation of cases which were treated by angle 6 keys in part 3 of this series of articles was that if you looked at the upper premolars and the upper second molar, the lower canine and the lower first molar, the position of the bracket should be different. It should not be exact at the center. You know, we were looking for the FSCC point, but if you bond at the FSCC point, you're incorrect. So what were the changes brought about? For the upper premolars, for the upper second molars, lower cuspids and the lower first molars, changes were made. For these three teeth, there was gingival positioning, 0.5 millimeter more gingival, and for the upper premolars, it was 0.5 millimeter more occlusal. So you needed to change the position of your bracket to be able to get good occlusion. So what did they do? They looked at good cases which had settled well and there was no posterior open bite and everything was in place. And they concluded that your brackets were not in the center of the clinical crown of all the teeth. So you needed to position the brackets differently. For the second molars, lower cuspids and lower first molars, you needed to place the bracket 0.5 millimeter more occlusal. Whereas for the upper premolars, it needed to be placed 0.5 millimeter more gingival. So what I want to say is that the bracket placement chart was very systematically developed. So when you use it, you have to be very careful. What you do is, step one, you take a divider or a vernier and measure all the teeth which have clinical crown heights, as many fully erupted teeth which are possible in the patient study model. So it's very important to have good study models. Followed by this, these figures are recorded, divided into half and rounded off to the nearest 0.5. And then, this is the measurement from the distance from the incisal edge or the occlusal surface. Then what you do is you look at the bracket placement chart and match it with the row which maximum number of entries are matched. So my suggestion as a PG teacher would be that always, note down what were the ideal, what was the line of this bracket placement chart you had chosen in your patient file, so that when the bracket debonds, you know what was the position which was selected ideally when this case was bonded. After that, for bonding or banding and bonding brackets, it's placed, look at the vertical long axis of the clinical crown so that you are vertically correct. For this, you will need an OPG to look at the root angulation. You have to be careful about the column angle. and use bracket placement gauges because they will tell you the exact position. Now, bracket placement gauges also need to be sterilized and kept clean. In the incisal region, the gauge is at 90 degrees to the labial surface. In the canine region, the gauge is placed parallel to the occlusal plane. In the molar region, it has to be parallel with the occlusal surface of each individual molar. Now, you have to be careful because many times you have bonded the bracket at a correct place and the examiner comes, places the bracket placement guide and finds your teeth in an incorrect position. For individualized bracket positioning, changes may have to be made. Like I mentioned, in deep bite and open bite, you have to place your brackets differently. Now, let's look at what changes you would make for individualized bracket placement. Try to understand that it's always better to place your bracket for the lower canine slightly mesially. It is often difficult to get marginal ridge leveled. A common error is to bond your premolars too occlusally, so you get lateral open bites. So as mentioned, when the chart was also being developed, where were the areas of concern were the upper premolars. Also bond your upper second molars fractionally occlusally than ideal. Now in the first premolar extraction cases, there is a good tip that you should bond your brackets 0.5 millimeter more gingival. 0.5 millimeter more gingival than what is mentioned in the bracket placement chart. If you had a second premolar extraction case, bond your 5s, your 6s 0.5 millimeter more gingival. So this will compensate for the lateral open bite which may develop. Also, checking your bracket placement is it's not a rocket science. It's very simple. The examiner will look at what? He will look at the horizontal errors. He will look in the mirror. He will see how horizontally your bracket is incorrectly positioned. He will look at the axial or the paralleling errors. He is going to look at the thickness errors, whether your composite is thick and this will not allow proper alignment of your teeth. He is going to look for errors in the vertical direction because that's going to change the torque which is going to be produced on that particular prescription. Now, what are the gingival concerns? Gingival concerns are that if there is gingival inflammation, the bracket placement chart of MBT is very good because it looks at the incisal edges. It doesn't look at the gingival level. Also, when teeth are palatally placed or facially placed, always look at them and do the necessary correction. There is a parallax error which happens. So usually if you will have a lateral incisor which is palatally placed, you will be able to see it at a lesser, you will be able to see a lesser length. So when the tooth comes forward, you find it at a different level and you'll have to change the bracket positioning. Similarly, a facially displaced tooth, you will be able to see a different length when it's actually present. So be careful while you're bonding these teeth. If an incisal edge is broken, with a temporary composite, build it up and then place the bracket at the correct place. Only when you want extrusion of a particular tooth where gingival levels don't match, then you will have to place your bracket atypically. If the canine tip is more prominent, round it off before you bond the bracket at the proper place. So now some examiners like to ask you, what is an adhesion booster? You want to increase the bond strength. So there are different adhesion boosters available like Mega Bond, Ortho Solo, All Bond 2, Enhance. So what are they basically? They are basically polyalkanoic acids and an aqueous solution of HEMA, which is thought to assist with moisture control. Remember we talked about moisture insensitive primers, MIPs. So they were polyalkanoic acid. So basically polyalkanoic acid and HEMA constituents are thought to produce moisture control and they enhance bonding. So why do you need to enhance bonding in some patients? Some non-compliant patients, somebody with hypocalcified fluorosis, excessive chalky enamel, or where difficult to bond teeth are encountered like an impacted canine. Mega bond promoters can be used for porcelain bonding, gold, amalgam surfaces. I'll just come to this one by one in detail. The promoters are not recommended with ceramic brackets. Ceramic bond strength is much more, so it can damage the enamel. Also, an adult patient presenting with enamel cracks or enamel defects or periodontally involved teeth, we should avoid using these promoters. So what do you do when you have a porcelain crown? Nowadays, adults want to go for orthodontic treatment. What do? You use hydrofluoric acid, gel, and sandblasting and silane. So a Scotch prime is preferable. Now there is a term called silicatization. What does it mean? You provide ultra fine mechanical retention by sandblasting, as well as a chemico-physical bond between the composite resin and the ceramic or metal alloy by using a silane coupling agent. So what is this called? The silica of the dental ceramic is chemically united with the acrylic group of the composite through silanization. So there are two words which every student should know. One is silicatization and other is silanation. You are using the silane group of your dental ceramic to bond with your composite. How do you bond to amalgam? Bonding is simple. You roughen your surface with a diamond burr, use an adhesive booster, use 4-meta acryloxy ethyl trimethyl anhydride. So 4-meta is used for amalgam. Sandblast the amalgam surface, coat this layer, and then apply sealant and bond. Gold surface by electroplating or tin plating with gallium tin solution. Now this, there are precious metal bonding agents like Panavia which are available, but this gold surface bonding is now out of fashion. In the 80s and 90s, people wanted gold teeth to show off that they had got dental treatment done and they could afford gold. But nowadays, this is not a popular aesthetic way of treatment. Also, how to bond resins and acrylic surface? Very simple. You roughen the surface with a diamond burr, apply phosphoric acid, and you are able to bond by using silanation. And first, for acrylic resins, wet it with an acrylic monomer, and the brackets are bonding with the bonding agent. Now, just the last 1 or 2 slides talking about what is the step forward. Many examiners want to know that this is okay, you've learned bonding, but what is the future of bonding? The future of bonding is in enamel preparation, widespread use of SEPs and molar tube bondings, lower concentration of acids, non-etching mediated bonding protocols, light cure sources, plasma arcs and LEDs, so that bonding time is reduced, more focus on the degree of cure. Why? Because an uncured primer has thought to have a mutagenic or a carcinogenic effect. Adhesives, what is the change which is coming up? Abandoning of two-phase chemical system, fluoride releasing ones for antimicrobial properties, so that the oral health is improved. Also, biomimetic approach. What do you mean by biomimetic approach? Dry bonding has basically copied the ability of animals like geckos to suspend their bodies by retentive forces or a network of filaments. And wet bonding is basically an effect of research imitating the capacity of muscles to attach to various surfaces like metals and polymers with the aid of specific proteins. So dear friends, bonding is a big journey. I want to conclude by telling you that when you are bonding, your bonding kit should be ready. The bonding kit should have everything autoclaved, sterilized in a pack, as every patient should be, used for every patient. You have to follow these proper steps in bonding. First step is cleaning with a slurry paste and cleaning the surface, good etching, good cleaning, good drying, followed by primer application, good curing. Your curing light should be clean. There should be a plastic covering on top for every patient, so that you are able to keep it clean, so that there is good sterilization control. So thank you very much for a patient hearing. And any other questions, any way you want to get in touch, you can email me at my email address. Thank you, dear friends.
Good afternoon to one and all. I would like to thank the IOS Head Office President Dr. Silju Matthew, Secretary Dr. Sri Devi, and Dr. Ashish Garg for giving me this opportunity. And the topic that I was assigned is Pedagogy, the Art of Speaking Extempore. Now, during the course of my presentation, and I would be very happy if even the faculty members who are there would take note of my presentation, because there's a lot of ambiguity and about this particular section of our examination. So we always tell our PGs to speak extempore. So by the end of the presentation, I hope I will clear some of the myths regarding pedagogy. So to start my presentation, so pedagogy is nothing but another word for education or teaching. It is everything to do with education and teaching, and it has a number of definitions. But the one that I liked best was the act, the process, or art of imparting knowledge and skill. So this is a very concise definition. Now, pedagogy is part of your examination process. So if it has everything to do with teaching, what is the purpose of pedagogy in your examination process? So basically, it is supposed to test your ability to teach. Okay, because in the medical and the dental profession, we do not have any specified qualification for teachers. So that is why this part of your examination tests your ability to teach. So please remember, you are not being tested on how much you know about this particular topic, but you are being tested on how well you can teach this topic. Okay, so it's this section has 20 marks out of the 100 marks that are allocated for the Viva Voce. So it is very important, and this is one section where you can prepare ahead and you can speak for yourself and you can set the tone of your Viva Voce. Okay, so the time duration is about 8 to 10 minutes, and the time is very important because it will tell your examiner whether you could express and cover whatever you want, what you want to say effectively in the stipulated time. So don't exceed the time. Time is extremely important. We have already said what you're being assessed for. And another thing is this extempore. What exactly is extempore? Extempore means spoken without preparation or without a planning or a script. So basically, when you're speaking extempore, it tests your oratory skills. It does not test your skill for teaching. But by the end of this presentation, you will understand that pedagogy is all about teaching. So unless you have prepared well, you cannot just present an extempore pedagogy. So the idea here of saying extempore is to make sure that your preparation is good. Okay, so don't get confused. Now, if you look at the origin of the word, it comes from the Greek word called pedios, means boy or child, and agogos means leader. So basically, pedagogy means a leader of a child. If you look at the history of pedagogy, now there is a lot of distinction between, in those days, in the ancient days, in the ancient days, there was a lot of distinction between pedagogues and school teachers. Okay, so these pedagogues were basically learned men who were often slaves or foreigners who literally accompanied their wards everywhere. They went to accompany them on the streets, they went to school with them, they even oversaw their meals. And they were the trusted by their masters to look after these wards and teach them the ways of the world. So in fact, children were kept in their charge by around 7 years and stayed there till adolescence. Whereas the teachers, the school teacher, was the person who taught the boy his letters or the school curriculum, and the pedagogue taught the child how to behave. So there was a clear distinction those days, where the teachers gave the instruction and education for the school, and the pedagogues gave them the guidance and the education for life. And these pedagogues were moral guides who were to be obeyed. Now the question arises, if pedagogy was had nothing to do with teaching, how did it become synonymous with teaching? So what happened in the later centuries, that there was a growing focus on teaching methodologies. A lot of debate happened on teaching methodologies, and eventually what also happened was that the traditional pedagogue system faded away, and that is how teaching became synonymous with pedagogy. Now, if you look at pedagogy, it is all about teaching. And if you look at it very critically, it is about the art, craft, and science of teaching. Now, art has to do with the intuitive, creative part. Craft is to do with the skill and the practice of pedagogy. And science has to do with the informed decision making and the theoretical foundation. Whereas lecturing or didactics is more to do with the content aspect, the delivery, how you are going to, what you are going to teach, how you are going to teach, and what is your purpose of teaching. Basically, that is there. Now, there are two terminologies that you need to know. One is pedagogy, the traditional terminology, and in recent years, another terminology called andragogy has come in, and which pertains to adult learning. Now, there is a confusion whether we should call our type of teaching pedagogy or whether we should call it andragogy, because we are adults and we are teaching adults. So basically, let us just go into a brief distinction between these two. Then you will know what our type of teaching can be called, and why you are presenting a pedagogy and not an andragogy in your exam. Now, pedagogy is basically a one-way dissemination of information from the teacher to the students, whereas andragogy is transfer of information from the instructor to the learner, and vice versa, and also between the learners. That is the main distinction. The other distinctions are that there is minimal preparation by the learner in pedagogy. The climate is very authoritative, it's formal and competitive. The planning is mainly done by the teacher, and the learning plans are dictated by the subject matter and the content. And the learning is mainly by memorizing, and evaluation also is by the teacher. Whereas in andragogy, the learner participates in content development, and there has to be a realistic expectation, because adults do not learn anything that is not of immediate use to them. So the climate is also relaxed, informal, and there is a lot of dialogue to and fro. Planning is also done mutually by the learner and the facilitator, and learning plans are subjected to the readiness of the learner, and they are problem oriented. Learning is also experiential learning, and evaluation is also done mutually. So at the end of it, I'm sure you will agree that the traditional thinking and practice of pedagogy can apply to both children and adults. So our form of teaching is also pedagogy. Now, there are a number of pedagogical tools that you can use when you're making your pedagogy. One of them is voice modulation and library resources, and of course the Blackboard. So please, you are free to use any of the pedagogical tools that you want to improve your pedagogy. Now, let us just go into a little detail about the 8 essential principles of classical pedagogy. We'll just take the ones that are relevant to you. So the first is festina lente, or it means that do not be in a big hurry to jump in and make a presentation. Please prepare well. So teaching to mastery. So that is the most important thing. Any pedagogy has to be well prepared. Next is multum non multa, which means do not put too much into your presentation. It beats the purpose. So the third is mother is the repetition of memory. Repetition is the mother of memory. So if you feel during your presentation that you need to repeat a few things just to drive the point across, don't think it is a negative point. You can repeat something to make your point. Okay. For example, your tip and talk values. I have noticed that most they forget their tip and talk. Something that will improve with repetition. Another thing is songs, chants, and jingles. I am not suggesting that you break into a song or a jingle in the middle of your pedagogy. But if you have any catchphrases which are good and which will help lend credence to your pedagogy, please use it. For example, TTT, like Zacharison loves to say, talk takes time, or bite before jet, something like that. If you can improve your pedagogy, you can always use it. Don't hesitate. The next final thing is wonder and curiosity. You have to create a sense of wonder, awe, and curiosity in your listener. For example, if you're talking about functional appliances, and if you show this pre and post photograph and say that you got this result in about less than a year with this simple appliance, don't you think it will create awe in the minds of your listener? Finally, effective lecturing. So effective lecturing is a major part of your pedagogy presentation. So basically, what is important here is that you have to prepare in advance. Also, you have to have a backup plan. If you are going to use some technology, say for example, a video or something like that, and if it doesn't work during your pedagogy, you must have a backup plan. Please prepare speaking notes and practice your lecture. Structure your lecture very, show your listener the big picture and cover only a few points. Don't cover too many points. In fact, it is said that in a 45-minute lecture, you should maximum cover 5 major points. Now, let us just do a teaching practice. So basically, a teaching practice involves all this. And we will take up the ones that are relevant to you. Okay, so first we will go to set induction. What is set induction? Set induction is nothing but bringing the mood into the topic. Now, if you're talking of surgery first, don't you think by showing these pre and post photographs, you will really set the mood for the pedagogy? So please do that. Use your visual aids to do that. Next is your topic. Here, mainly the title comes into the picture. So make an issue of your title. Make your title catchy, make it interesting so that it increases the interest in your pedagogy. Next, and the most important thing is how you are going to organize the topic. And you have to keep in mind these 4 things. The time management is the most important. Like I said, it tells you whether you have effectively conveyed your message in the stipulated time. Next is your editing. It has to be smooth, remove all unnecessary things. So keep practicing, then your editing will also automatically improve. The next 2 are relevance and sequence. I'm going to look at that in a little more detail. When you look at relevance, whenever you are talking about any subject, you must bring out the basic relevance. For example, if you're talking about surgery first approach, you have to bring the relevance of the time saved, and then avoiding the worsening aesthetics, and also the immediate gratification that you give your patient in terms of improvement of aesthetics. So all these things you have to, you cannot miss out. Second is your sequence. Sequence is very important. Each individual will use his or her own sequence. So for example, here in surgery first itself, you can use 3 different sequences. Now you can approach it from the logical treatment procedures, like you can talk about your diagnosis, workup and execution, or you can go from simple to complex. For example, your single jaw, bi-jaw and your multiple osteotomies. Then you can also talk in terms of the type of malocclusion. For example, you deal with your class 2s, class 3, open bite, deep bite. You can go in that sequence. And now we come to the most important part, that is the body of your lecture. This is the most powerful point of your presentation, and you have to give due thought to this. So it must have your critical information. What do you mean by critical information? Now, if you are going to talk about, say, distraction osteogenesis. Now, when you're going to talk about distraction osteogenesis, you have to bring out the fact that you are creating a callus and you are distracting the callus. Very often students think that they are distracting bone fragments. No. So this is a critical information. Secondly, if you're going to talk of accelerated orthodontics, you have to bring out the critical information that you have to create an osteopenia in the bone. Without osteopenia, your teeth are not going to move faster. So this is what you mean by bringing out the critical information. The next thing is it should be very well organized. So that is where your sequence comes into play. So for example, if you're going to talk about the management of class 3 malocclusions, then you have to talk of growth modulation, then you have to talk about camouflage, you have to talk about surgical. So all this should be very well organized in a logical pattern. So third is the general theme. Any topic will have a general theme which will bring all the other aspects together, and these should be woven very well together. The next and a very important thing is sufficient depth and complexity. Remember, you are speaking in front of examiners. So it should have sufficient depth and complexity. It should not be very superficial or frivolous. And finally, your testimonies and your exhibits. Keep in mind your hierarchy of evidence and bring in your literature references here, and also maybe you can bring in a case report. Finally, please use all the reinforcement that you can use. For example, you can use facts and figures, you can give examples, you can use audiovisual aids, and most important, please maintain eye contact. Finally, summarizing is very important. Close your lecture with a brief and powerful summary. Okay. Now, to recapitulate, now planning your lecture, organize your thoughts and your information. That requires a thorough research. So it cannot be something that you bring up in a day or two. It has to be well researched. Write down what you want to say. So you bring out the relevance in your pedagogy and put it in the right sequence. Then practice your pedagogy, very important. And then time yourself, extremely important. Then these are some of the common mistakes you must avoid. For example, trying to cover too much material. Please, they are not trying to see whether you have covered everything under that topic. No, they are only trying to see whether you can teach that topic effectively or not. Okay, so don't try to put too much material. Not looking at the examiners when you're speaking. You are teaching them effectively. Why? How can you not look at them? Please look at them. Maintain eye contact. Also, don't look only at your slides. And the last and most important is filling too much material in your slides. Please avoid that. So these are your 8 minutes of fame. Okay, use them very effectively. Use your pedagogical tools effectively, use your auditory inputs effectively, use your visual tools effectively, and keep your examiners enthralled. Thank you for a patient hearing, and I wish all the exam going students the very best.